Hi guys, this is Dr. Davis. So this will start our very first maternity lecture on Antepartum. I did split this up into about 20 slides just because I think it's easier for you all to listen and it's easier for me to lecture. So it benefits both of us this way. So we will be moving through our first section on Antepartum. These are our learning objectives for this lecture as well as the other half of the lecture. So part 1 and part 2. These are the things that we're going to be covering. I will cover a little bit more of some of these things in class just to hopefully clarify and walk through this information because I know it's brand new, totally different than everything else you've learned so far. All right, so this first 2 lectures are going to talk about antepartum nursing care. So antepartum is from the time that the person becomes pregnant until they go into labor. Intrapartum is that part where they labor and deliver, and then postpartum is going to be after delivery. So we're going to talk about the beginning of pregnancy up to childbirth in this next 2 lectures. All right, so these are medications that you will need to know for the whole of the maternity section. I did go back and note for you which ones you needed to know for exam 1. The rest of these you will need to know for different exams as we move through. And we'll discuss them as we go through. Now on the right is the active learning template. Ms. Parrish sent those for you so you could start working on those. I find them very helpful. They narrow down the information quite nicely. There are more of these that I will have posted for you in Canvas that will cover a whole bunch of different things. Students have really liked them. It narrows down the amount of information that you need. So feel free to use these throughout this semester. Okay, so we will be talking a lot about the female reproductive organs in the first half of this class as it relates to childbirth and having a baby. So please review your anatomy, the ovaries, fallopian tubes, uterus, cervix, and vagina. All those pieces will be important, and we will be discussing them quite a lot. Conception or fertilization is actually the union of the sperm and the ovum or the egg. The egg lives for about 24 hours. Sperm can live in the vaginal tract for 72 hours. Menstruation is usually 14 days after ovulation, and then fertilization can take 7 to 10 days. Usually that happens in the fallopian tube, but not always. Okay, so some of the things that we're going to talk about are the signs of pregnancy. So they like to classify these into 3 different groups: presumptive, probable, and positive. All right, so basically the difference is, how do I know I'm pregnant? Okay, so the presumptive signs are those that mom feels. Okay, so the patient says, my breasts are very tender, I missed my period, I have nausea, vomiting, I have to void very frequently, and I'm tired. So those are presumptive signs. Those are the ones that if people start having them, then, talking with other family members or whatever, they will say, oh, maybe you're pregnant. We'll presume that you are pregnant. Okay. Probable signs of pregnancy. These are, and I tend to call them those guys, because it's a list of different signs, all named after men who have discovered them or have decided that those were their signs of pregnancy. So those probable signs are the list of those guys. Okay, so that's Goodell sign, Chadwick, Hagar's, Braxton Hicks. All those things are probable. Okay, and the thing to know about these are that they're all changes in the cervix or in the uterus. So your Goodell's is the end of the cervix will soften some. Your Chadwick is the bluish color of the cervix. Hagar's is a softening of the lower uterus. And then Braxton Hicks are your false contractions. Typically, we don't see those till later on, but you could have them sometimes earlier. A positive pregnancy test is considered a probable sign, just because I don't have a good reason why. I know that sounds lovely, but I feel like it probably shouldn't go in this category, but it does. So don't let Dr. Davis screw you up on the answer, okay? They are telling you that a positive pregnancy test goes in here, okay? Ballottement is actually when you are actually checking a patient. So you're checking to see if her cervix is dilated, and you can touch the baby's head actually, and the baby will kind of swim away from it. You can feel that. It's a little crazy. I know it sounds crazy, but it happens. So those are those presumptive and our probable signs. We're going to talk about our positive signs in just a moment. Okay, so these are our positive signs of pregnancy. So these are, I can see a baby on a sonogram, right? I have the sonogram wand on this person's abdomen. I see the baby moving around. That is a positive sign that they're pregnant, okay? Hopefully everybody understands that, right? If I'm doing an ultrasound and I see a baby, I can hear the heart tones. That's a positive sign I'm pregnant. I can hear fetal heart tones by a fetal stethoscope. We'll talk about that one later on in a few slides, I do believe. Never seen nor used a fetal stethoscope, okay? Usually you're going to see a Doppler, which is the small little machine with a wand on the end that we'll listen to heart tones with. Also a positive sign is feeling fetal movement or seeing fetal movement. Those are all considered positive. All right, so some maternal changes during pregnancy that we're gonna see, and we'll break these down a bit more in class. So our pregnancy length, so you count that from the first day of your last menstrual period. Usually it's about 280 days, which is 40 weeks, which is 10 months. We say that it's 9 months. My theory is it's just a trick, Mom, because it makes her feel like she's only pregnant for 9 when really she's pregnant for 10. But that's just a free Dr. Davis theory. I have a lot of them. Pregnancy is divided into 3 13-week trimesters. So you have the first trimester is the first day of the last menstrual period through 13 weeks. Second trimester is 14 weeks through 26 weeks. And third trimester is 27 weeks through 40 weeks. So some of the psychosocial responses that you're going to see during pregnancy, that first 13 weeks or so, mom may have some ambivalence. even if this pregnancy is planned, she may feel ambivalent or unsure about the pregnancy, only because, I've wanted this pregnancy. We've done all kinds of things to become pregnant, but now that I am, oh my goodness, I'm going to have a kid in 10 months, and now I'm not sure what am I doing, okay? And that's sometimes just a planned pregnancy, right? Unplanned pregnancy, mom may have a lot of ambivalence, right? I wasn't planning on being pregnant at all. This is not what I wanted. So those feelings are normal. Second trimester, usually you're starting to feel some quickening or baby movement. You will hear us use that word. Quickening is the first fetal movement. They usually will ask you that question, when you are pregnant, when's the first time you felt fetal movement? And that's what they're looking for, is that quickening date. Usually once mom starts feeling baby movement, things become very real. The woman now is more acceptance of that pregnancy, not as ambivalent. So I'm starting to be a bit more acceptant. And then in my third trimester, mom really is focused on herself, on the birth process, on becoming a mother, on taking care of this baby. What does my future hold? So there may be some strain in the relationship as mom is now focused more on herself and the process that she's going through rather than on her partner. So some other responses to pregnancy. So throughout the pregnancy, you will see wide mood swings. I may go from being very happy to very scared to being anxious, all at the same time. A pregnant woman is very sensitive, or ultra sensitive, right? Even more sensitive than normal. And there may be a strained relationship with the partner. Towards the end of the pregnancy, the mom should be doing a lot of maternal fetal bonding. So you may see her rubbing her abdomen. She may call the baby something, a nickname, Peanut, different things like that. If maybe I'm going to go ahead and use the baby's name, and I'm going to talk to the baby a good bit. Okay, so as I come in, there'll be two different ways that we'll record the obstetrical history of this patient. So GMP is gravida and para. So gravida refers to any pregnancy, no matter how long that pregnancy is. If it was 4 weeks or if it was 40 weeks, it counts as a pregnancy. So that is your gravida. Your para is how many times after 20 weeks your uterus has emptied. So even if you had twins or triplets or quadruplets, your uterus only empties one time. So you may be the mother of quadruplets. And if it was my first pregnancy, it's going to be, I'm a gravida 1, para 1 once the baby is born. Babies are born. And then what we will say is they have a living 4. So they have 4 living babies. Just to break that down a little bit more is the GT-PAL. So that is actually breaking it down even a bit more specifically into the G is the number of pregnancies. T is term, so any full-term birth, 38 and up. Preterm is going to be any pregnancy 20 to 37 weeks. Abortions and miscarriages will go under A. Officially, the word for a miscarriage is a spontaneous abortion. And so that is any pregnancy that does not reach 20 weeks. And then living children are the infants that survived birth. Okay, so if I had a preterm baby at 20 weeks, I might be a gravida 1 with a preterm of 1 and living 0, because maybe that baby did not survive. So we will do a few of these in class together. On this slide, we talk about a few of the terms that I want you to know. So nulla gravida is someone who has never been pregnant before. A prima gravida is a patient that is a first-time pregnant. Multigravida is a patient who has had 2 or more pregnancies. Typically what you will hear these even shortened even more. So you're going to hear a prima gravida as a primip and a multigravida as a multip. Okay, those are just the verbiage you will hear once you're in the labor and delivery unit. Viability. So if I'm talking about the viability of a baby or of a fetus, I'm saying that this is the youngest age that this baby can survive outside of the uterus. All right. So when I started in OB, that was 24 weeks. So if by chance someone came into our hospital, and you know I worked here locally at Lakeshore, we had someone that came in, maybe their water was broke and they were at 23 weeks. We would, as long as they weren't delivering right away, we'd do our best to, we'd actually put them in Trendelenburg. So we would tilt that bed upside down. So basically her head is going to be pointed at the floor with my legs kind of up in the air. We're going to put her in Trendelenburg and try to keep that baby inside for another week until we can get her transferred to UF. So our tertiary care center was University of Florida at Shands, because they have a level 3 NICU. Okay, if that did not work, if she was still 23 weeks when she delivered, there really was just nothing that we could do. There we would, assess the baby once the baby came out. We would do what we could, and then Shands would come and pick baby up, and then also do what they could to ensure survivability in these babies. Okay, so that was when I first started in OB. They've now decreased that gestational age to around 22 weeks. And we'll talk a lot about this as we move through OB, because there's a lot of ethical questions for us to discuss here. Fetal age, so preterm is considered 20 to 37 weeks. Term is 37 to 42, and post-term being after 42. This also has changed. When I started, preterm was considered 20 to 35 weeks. Term was 36 to 40, and post-term was 40 plus. So, like I said, these things change in OB just like the rest of medicine. Okay, Nagele's rule is something you absolutely need to know for both your NCLEX and for testing purposes. Okay, so Nagele's rule is how to estimate the baby's due date by doing a quick little math problem. Now, those of you who had me in foundations know that Dr. Davis does not math. So we will discuss this, and we'll do a couple of these in class, but just kind of memorize this little formula. It does make better sense once you start doing it. Okay, so you're going to take the first day of your patient's last menstrual period. You're going to subtract 3 months, and then you're going to add 7 days and a year. Okay. So for this example, down here, you've got September 9, 2019 as your last menstrual period. So if you count back 3 months from September, you have August, June, July, June. So June is 3 months back. Then I'm going to add 1 year and 7 days. So I'm going to add June 9 and add 7 days will be June 16. Add a year, making it June 16, 2020 as the due date. Okay. In regular practice, I absolutely never use this. Okay. But for some reason, they still put them on NCLEX, and it is on your test. So please know how to do it. How did we figure it out? We used these handy dandy little wheels that's in the picture down here. And then once we started electronic charting, the easiest thing was just to type it in and the computer figured it out for you. All right, so office visits and weight gain. So a low-risk client or patient office schedule visits are going to be every 4 weeks until 28 weeks, every 2 weeks from 28 to 36 weeks, and every week from 36 weeks on. Now, what do I mean by a low-risk client? So a low-risk client is someone that does not already have blood pressure problems, that's not already a diabetic. So a young, healthy woman of a normal BMI, a normal range weight, will be considered a low-risk pregnancy. As long as it's one baby. You know, when you start throwing a second baby in there, any other issues, that makes you not a low-risk client anymore. How much weight should a patient gain? A normal, healthy weight patient, not someone who's fluffy as myself, should gain 25 to 35 pounds. If you are already heavy, then your weight gain will be much less than that. All right, fundal height measurement. So beginning 12 to 13 weeks, the fundus rises above the symphysis. What the heck did I just say? Okay, here's your translation. Your fundus is the top of the uterus. All right, the symphysis pubis is that bony structure that is your pelvis. All right, a typical uterus you should not be able to feel outside of that bony symphysis pubis pelvic region. Okay, it's not until the baby starts growing and getting bigger that you're going to be able to feel that uterus. So the fundus is the top of the uterus. So as that baby gets bigger, that uterus has to stretch and grow. So if you look at your picture here on the right, it shows you weeks of gestation and how that uterus grows as that baby grows. Okay, so why are we talking about this, and what is this lady doing in the picture? All right, so we're going to talk about that next. So she is measuring from the top of that uterus. So I'm going to feel, and you'll be able to feel it. It feels like almost like a full balloon. So the top of a balloon is what I'll be feeling, and I'll measure from there to the top of that pelvic bone. And that measurement, if I do it in centimeters, should be about the same size as what the baby is in gestation. So let me translate that a little bit better. So if my baby is 24 weeks gestation, right, I've been pregnant for 24 weeks, my belly should measure 24 cms. Okay, so it's kind of a quicker, easy way for us to measure. Now, sometimes you'll have a baby, you'll be a little bit smaller or a little bit larger than that, but it's kind of a easy, quick and easy way to verify how is baby growing. All right, so fetal heart rate, how do I hear it? How do I know what it is, etc. So remember I talked about the fetal stethoscope or the fetoscope? That is what this lady is doing over here on the right. How the heck does that work? So Do you remember when we did foundations and we did our neuro assessment and we used the tuning fork and we would place those on different bones in our head and you could hear it, right? Same idea. So they're using the bones in the head to conduct the heart rate, and you're able to actually hear it in your ears. So that is what they're doing. I have never seen nor used one of them, and I'm not sure why they're still being included in everyday OB lectures, but for some reason we still need to talk about them. Okay, so I have. Typically, though, what you're going to see is the use of a Doppler, which is the bottom picture. So that's the same machine that you use when you're trying to listen to, say, pulses, and maybe I've not got any good pulses. I can't palpate them, so I'm going to go grab a Doppler and listen to them. Same machine. Okay, the only difference is you see the transducer, the piece that actually is touching the patient, that is changed. Okay, so it's a circle and flat, where the one that you usually use to listen to veins is very small, and it's also flat, but it's very small and pointed, so you can really pinpoint that to the vein. So usually about 10 to 12 weeks you can hear baby on that Doppler. Now please understand, if you have some extra adipose tissue, it will be a little bit longer before you're able to hear your baby's heart tones, okay? But that's perfectly normal. So our normal fetal heart rate should be 110 to 160. That is something that you need to know for sure, because we're going to talk about it a lot. Usually our heart rate changes are how we know something's going on with the baby. Okay, so what do I mean by that? So if I come to listen to your baby and the baby's heart rate is, say, 80, I'm going to say, something's happening. Baby's rolled over on its cord. Maybe that placenta is not working very good. So I'm going to do some things to try to make that heart rate increase. So heart rate is the number one way that we know something is going on with that baby. All right, so some things that we need to know. What do I need to tell my mom if I'm working in an OB office? So if I have a patient that's in the first trimester, so that's those first 13 weeks, right? She's going to experience nausea, fatigue, and urinary frequency. I'm going to be sleepy. I need to rest a lot. If I'm someone who already exercises a lot, you should be fine exercising. You may need to slow down a little bit and not do quite as much, but that is something you'll need to discuss with your physician. Work is fine, but you don't want to be somewhere where you're going to be exposed to hazardous chemicals or toxins. Bathing is fine as long as your membranes have not ruptured. You may travel by car or air. Both of them are fine. You just need to take frequent breaks. Make sure you wear your seatbelt and get up and walk around. And you don't want to take any medication that you've not discussed with your physician, nor do you want to drink alcohol or smoke if you can help it. In the second trimester and towards the end of the second trimester, we will be more concerned about what's going on in this picture over here. First, let me back up though and say that we want to make sure that you are receiving your regular dental hygiene appointments. You don't want to do any major dental work unless you need to, but there are some studies that show that dental infections can cause issues with pregnant women. So you still want to follow up and make sure that you're seeing your dentist like you should. Now, as that baby starts growing, towards the end of that second trimester and into that third trimester for sure, we have problems with supine hypotension. So what does that mean? So looking at this picture, you see the baby in this picture is quite large, right? So the baby, the placenta, there's fluid in there. In between that uterus and the spine is your inferior vena cava. That inferior vena cava is that big artery that carries blood to the bottom half of your body, okay? So if I lay flat on my back, that uterus and baby squash that artery, my blood pressure is going to drop, right? Because I'm not getting any blood to the bottom half of my body. Mom's going to feel faint. She's not going to feel well. She's going to feel be hot and kind of sweaty, feeling a little clammy even. So we don't want moms to lay flat on their back as that uterus starts to get larger. So we're going to say that she needs to stay laying on that on her side, one side or the other. Or if she needs to lay on her back, then you want to tuck a pillow underneath one hip so she's tilted slightly. Now into our third trimester, we want to make sure mom is getting into childbirth classes. We're going to tell her that she's going to have a lot of urinary frequency because now baby is much larger. They're going to be in there kicking and bouncing around on that bladder, so she's going to have to go to the bathroom more often. Same thing's going to happen with my lungs. Everything gets squished up, right? Things get squished up and down for that uterus. So I'm going to have more shortness of breath. Things that are normal during this time are leg cramps, nasal stuffiness, developing varicose veins, and constipation. So we need to do some teaching about those things. Balance, mom's going to be very much off balance. We're going to tell her to use pillows to support herself, especially when she's sleeping. Round ligament pain is for reals and is very, very painful. So those ligaments, what they do is they help to hold up that pregnant uterus. As the baby gets bigger, those ligaments will start stretching and it's very painful. So we may tell mom to wear one of the belly support bands. We'll have her come to the hospital when contractions are happening every 5 minutes. We're going to want to talk about feeding. How am I going to feed this baby? What pediatrician am I going to go to? And some of the risks or symptoms of preterm labor.